Good afternoon, everyone. Welcome. We're going to get started so that we have the benefit of our full 75 minutes here together, because I suspect that this is going to be a really raucous discussion. So welcome to all of you. Thank you for joining us to explore this really critical and I think underexplored topic of failure in healthcare. My name is Danielle Martin. I'm a family doctor, and I'm also the Vice President, Medical Affairs and Health System Solutions at Women's College Hospital here in Toronto. I think that the fact that all of you chose to spend the afternoon session with us today speaks to a desire across the healthcare system in Ontario and beyond to start engaging in a conversation that I think is really long overdue about how we identify, name, and learn from failure in healthcare systems. So many of you, I think, in this room attended our full-day conference on failure in healthcare, which was co-hosted back in March by Health Quality Ontario and Women's College Hospital. And that conference, I think, was an enormous success in terms of how activated people got. The feedback on it was really terrific. I should point out before we begin that we, as presenters, have no conflicts of interest to disclose or commercial support. We hosted this conference in March, co-hosted by HQO and Women's College, to try to get this conversation going. And I think what we learned out of that process was that this is an area that people really want to talk about, and yet it is very difficult to know what to do when the conversation is over, because the follow-up is very unclear. And on reflecting on that, I think both Joshua Tepper and I realized that it's because this ever elusive concept of culture change, which is what we're really trying to get at, we don't have any real avenues to move that forward. And so it was felt that having a follow-up session today was one way in which we could at least keep that conversation going. In Ontario today, healthcare institutions are beginning to recognize that there is a value not just in owning up to healthcare system failures, but actually publicizing those failures as a means to learn. And I think you've already seen some of that learning taking place at Health Quality Transformation in some of the presentations today. And I do think that those efforts to increase public reporting, many of which actually arise out of the terrific work of HQO, are intended not only just to drive transparency, although transparency is key, but because we recognize that talking about system malfunctions is what helps us, or one of the things that helps us to drive quality improvement. So we're moving away from a way that we used to think about failure as a liability, a legal liability, a clinical liability, hopefully towards a slightly more enlightened state where we think about failure as a learning opportunity. And I think that in well-established healthcare institutions like hospitals, that culture change is underway, and we see it happening. We see the reporting of hospital-acquired infection rates. We see conversations about falls and about, medication mismanagement, et cetera, in hospital systems. And that seemed, it would seem to be that is hard enough, frankly, to get our healthcare organizations transformed into that kind of learning community. But at the next level up, above the institution, when we start talking about healthcare systems and healthcare system redesign, I think that the job of learning from failure has only just begun. Because once you move to that higher level about and acknowledge that some of the things that we do in the way that we design healthcare systems will work and some of them will not, that begins to require then a culture change in government, a change in the media, a change in the way that we talk about the purpose of systems in our civil society, and that is a much greater challenge. So why do we need to talk about failure in healthcare at all? Well, we know that our healthcare systems in many places have ossified and are failing to provide the kinds of services to the communities and citizens that they want, need, and that they deserve. So if we want to respond to the changing needs and we want to actually take on issues of health equity, we are going to need to do things differently than the way that we've done them. And that means that some of the stuff we're going to try isn't going to work. So as any entrepreneur will tell you, innovation is a risky business. And we talk about innovation as being risky, but I don't know that we really know how to walk that talk when it actually comes to changing the way that we deliver healthcare services. And if you think of the commonly quoted statistics that 50% of new startups fail in their early years, and in the corporate world, this is something that's sort of taken as a given, I think you can see that we probably have a long way to go in terms of acknowledging failure in our own sector of healthcare. In fact, numerous sectors outside healthcare, including sectors where lives are on the line, have taken on this notion of failure as being the necessary companion to success, or the flip side of innovation. So there's books out there, endless ones, to fail early, fail often, fail hard, fail this, fail that. Everybody's talking about failure in every other sector of the economy. You've got the Harvard Business Review devoting entire issues to the concept of failure. And as if on cue, this past Sunday, the New York Times Magazine ran its entire issue on failure in the corporate sector. And this magazine is filled with analysis and examples of failures all across different aspects of the economy. And it's full of stories of failure, and not just that kind of trite thing of failure en route to success, but also just plain failure. Things that didn't work, not that didn't work and then led to the great, $1 million idea, but just things that were tried and didn't work out. So today, we're not actually interested in just kind of skimming blithely over stories of failure as the necessary route to achieving success. I think we want to try to sit a little in the discomfort of the places where what we try doesn't work and we don't yet know our way through it. Because I think it's through those stories that we begin to understand how do we build systems and cultures around us that can deal with and cope with that discomfort. So that's what we're going to do over the next hour or so. We have two terrific and, may I say, very courageous healthcare system leaders who have accepted the challenge of coming today to talk about stories of failure in their own work. And they're going to reflect a little bit on how do you create organizations and systems that can identify failure, can be unafraid to name it, and can learn from it as the necessary flip side to innovation. So the way that things are going to work today is we have two panelists whom I'll introduce in a moment, and each of them is going to present a brief story, really just 5 minutes. And I'm going to interview them a little bit to try to tease out some of the system implications in the stories that they're bringing forward. They're both two really terrific stories. And we're going to have some back and forth, and then we're going to try something new, which is that these two seats to my left, your right, have been reserved for you. And instead of doing a traditional question and answer where you put up your hands, you are invited to join what we call the Fishbowl in these seats and to participate in the conversation, either by asking a question or sharing a reflection that you think is relevant to what's being discussed. So we want you to treat it as a participatory thing. Of course, we don't want you to stay in the seats forever. The idea is that audience members will rotate through, but we do want it to be a conversation, so you don't need to feel as though you have to have a 10-second question or not get up at all. So with that, I'm going to introduce our two panelists. Camille Orridge is the CEO of the Toronto Central LHIN and is therefore ultimately responsible for planning and managing local healthcare services in what is undoubtedly one of the most complex environments in the province and perhaps the country. Camille has received many accolades for her passionate advocacy for developing strong and inclusive communities. Most recently, she was awarded the Queen Elizabeth Diamond Jubilee Award Medal in 2013 and an African Canadian Achievement Award just this year. She holds a master's degree in health administration from the University of Toronto, and she's a long-standing member of the Canadian College of Health Service Executives. So welcome, Camille. And Michael Scholl, Dr. Michael Scholl, is the president and CEO of ISIS, the Institute for Clinical and Evaluative Sciences, and he's a professor in the Department of Medicine at the University of Toronto. His research focuses on health service utilization, quality of care, and patient outcomes, particularly as they relate to emergency care. He has a particular interest in interventions to reduce emergency department waiting times and innovative ways to better integrate care between hospital and community services. Dr. Scholl practices as an emergency medicine specialist at Sunnybrook in the north part of Toronto. So, without further ado, I'm going to put Camille on the hot seat. you want to stand? You can sit if you want. You've got a lapel mic.
So, thank you all for coming to listen to this presentation, and certainly is a pleasure to be here. A little bit nervous, but still. What I want to talk about is, you all know or may not know, but in Toronto Central Lynn, it's the only truly urban Lynn. We have no larger areas. So we pride ourselves, and we champion the whole notion of equity and patient engagement. And we pride ourselves that we're going to then do engagement outside of the mainstream. And so our identity is tied up with this. My own personal identity is tied up with this. And so last year we had it on our board agenda. We told the board we were going to do some things. It was on my personal performance that we were going to deliver this. And at the end of the year, when we were doing our year-end report, we had a big red on patient engagement. And that was a hard one to identify, to realize, and to acknowledge. Now, we have a lot of type A's like myself at the Lynn, so this was really personal. And how could we do this? How can we do this? And the first thing we do is like what every other organization do. We spend the first few hours figuring out what went, not how do we fix this or what, but what did we do right? We take the defensive. So we have to defend ourselves. We have to defend to the board why we didn't deliver. And so it took us a while, and this is where good teamwork come in. So we started to laugh about this and, thinking, okay, one red isn't bad, okay. But it's our identity, right? However, we went through it and we had to acknowledge that it's a red, and we need to then really figure it out. So what the story was, we went into a neighborhood called Mount Dennis because we said we were going to go into neighborhoods. And we went to neighborhood Mount Dennis, which is the western part of large immigrant population, higher than average single parent family, a lot of immigrants, etc. And we did an engagement. And we got a report. But then when we really looked at it, we were successful in that we finished the engagement, we got the report, we could have put a green. But the real truth is, nothing of that what we heard from this engagement, we acted upon. And if we look at the scorecard this morning, so for us, if we had to acknowledge the fact that we didn't action anything, and so we start to see that as a failure. Because now we have failed the community. So the community came, they really spent time, they trusted us. So what happened? And we learned a number of things through going through that other analysis. The first one is we had what we thought was a great idea of having a patient and a patient representative lead this initiative. And that was a good idea. What we didn't do was to be clear about what our ability to deliver was. So we had people coming to us with all kinds of things that we had no capacity to deliver on. But we didn't think that was a good enough excuse. So for the next round, when we went into St. Jamestown, we partnered. So we partnered with Public Health, we partnered with United Way, and a number of providers, and we did the same thing. In this round, what the community told us they wanted was, senior services and dental care for children. That was their number one priority. Not access to primary care, not, because we had a number of immigrants, again, with kids, and their kids were their priority. So Public Health was able to deliver on the school bus. So that was a big learning, that as we're now going out and doing this work, we need to, first of all, partner, choose wisely in going in. And I guess I would just like to say that, to me, as we talk about patient engagement, that's where the big risk is. Because I'm saying we're all failing, all our communities, and all the engagement work we're doing is good, but it only addresses half the population. So that if we're doing patient engagement or services and it's not translated into language that the recipient understands, we're not doing it. So how do we have those conversations now as we begin to build patient engagement, that we have these communities? And we're going to fail a few times because none of us have it right. None of us know how to do it. And how do we not get defensive about it, but embrace it? Because I think this is the biggest risk to us as a healthcare system in patient engagement, is not to know it's going to cost us more, it's going to cost us more time, but none of us are experts in it, and that's the way we need to go. So we'll answer any questions as we go forward. Thanks.
So just before Michael comes up, I'm going to just probe in two specific areas, Camille. The first is I'm trying to picture the conversation with your board chair. When you come to her ahead of the board meeting to say, this is what we're going to present, and we've got a big red on the area of engagement with marginalized communities. So what were some of the, if you're comfortable, can you describe the conversation for us? I'm trying to get at what are some of the words that get used in a culture that is failure resilient, or at least where it's allowed as a beginning.
So I think the first thing was the relationship with the chair. So I sit down and I says, we did good work, we worked our butts off, we've done a lot of delivery, but nobody, including me, expect 100% green. So let's start from there. The bigger issue for us wasn't that it was a red, it was the area in which the red occurred. That was the hardest part. If we had been a red in MRI wait times, it would have been a totally different one. It was because it's so tied in with our identity that it was that much harder. So we talked about, yes, but this is why we think we have failed, and this is why we could put it as a green, because we did get the report, but let's come up with a new criteria and let's acknowledge, and that will be the bigger advantage to us to go forward. So by switching this to the opportunity of what it will mean to us going forward, it really changed the face of the conversation.
So I do think that is something that happens a lot in healthcare systems, where things don't go as we planned, and we sort of paper it over and say, oh well, we achieved these process outcomes that were meaningless, or we managed to spend the money on time, or some other thing that is of no consequence to actual human beings, and we're avoidant of the true failure that sits at the core of that. So what is it in your own leadership and in the leadership of your executive team that allowed all of you collectively to look at this and be honest and say, what, we failed?
I think the culture that has emerged in Toronto Central, Lynn, even as we do Health Link works, etc., is that we feel a direct accountability for the residents who live there. So we feel our job is to make a difference in the lives of the people who live there, and not only those who come into care. Because we know there are lots of people who are not currently getting care that should get care, but aren't having access. So I think we have spent the last 2 years as a board and the senior staff building that type of accountability, so that we can have the conversations that way. And so by then looking at the neighborhoods, and we also push hard in terms of saying to staff, your job is not at the office. Your job is out there in the community. So we have things like our boards going out to do Meals on Wheels in areas that in their lives they would never go into, because we've got to see people where they live. And so I come from the CCAC community sector, so very comfortable with knowing you have to go into community and into homes, and not when people come to you. So I bring that. So by getting all of our staff who may go into St. Jamestown, but normally in their lives would drive by it and would never ever have a clue what goes on in there. we spent a lot of time doing that. The other thing is we also spent time, which was also a challenge at the beginning, just chilling and talking. We're all type A with agendas that start here and there and there. But half the time, the great conversation doesn't take place then and there. Sometimes you have to spend more time. And so you have to invest in the culture.
Right.
I guess that's what I would say as a leader, and owning more than the job. And I think it has to be tied back to patients and people. And if you start from there, I think it helps.
So that's great. And as a follow-up to that, I think many organizations struggle with how do you strike that balance between setting goals that you can actually conceivably deliver on. So this thing about making sure that you frame it in a way that the information, so you go into Mount Dennis and you say, well, tell us everything that you want. They're going to give you a whole list of things that you can't do anything about, then it's going to be hard to respond. And yet on the other hand, there is always a risk of setting the goal that is, you could achieve in your sleep just so that you can get the green. And so, and I think we see that in family health teams and hospitals with the process of developing quality improvement plans. When you set the bar really low, query what we're doing any of this for anyway. And so can you talk a little bit about in your second round, when you went into St. Jamestown with the learnings of Mount Dennis, how did you strike that, how did you still give a stretch goal to yourself without without tying your hands behind your back?
This time we had some other folks who helped us to go in. They found what we now call community animators. So these are people who live in St. Jamestown, and then spend time with them saying, here's who we are, here's our limitations, but here we have a commitment that what we can do, what we can't do, we will work with you with others to get it done. We're not just going to drop it. So we then took on what we call the influencing role. And so with that, we then looked at who the other partners should be. Public health, we thought, was a great partner. A lot of public housing is in there. So we had housing, public health, United Way, because United Way is another funder. And so some of the programs that they needed, funding may come from other sources. And those animators were the folks who did the great job. Because they then, one animator who came and presented to our board said that she knew if she went and knocked on the door, nobody's going to open the door. So she didn't even bother trying knocking on people's door. She went to the bus stop in the mornings because that's when all the moms were on the way to school. And then that's where she talked to them. And our lady said, well, I go to the Filipino store because all the Filipinos come into the store to buy food. All the Jamaicans go into the store. So they knew in their community where to go and meet people and talk to them. And then we had a big session where we had over 300 people in a room with different languages, and we fed them back what we had heard and had them confirm what they had said. And out of that, we came up with a list of actions, and our commitment was to be there. So we're there a second year now with more programs, and then we're going into a third year. But some of the things that are being delivered are not LIN funded and not LIN.
Right.
And the CCAC, for example, as a provider, has changed their entire model of service there. They now have teams in there because people are saying, we're tired of seeing 50 different nurses coming. We don't know who they are. So now they have a set that the community now knows. So getting the providers to participate was also critical.
Michael, do you want to jump in?
Yeah, just sort of listening to you, one thing that strikes me is that what it sounds to me like you're describing is not just about patient engagement. So by virtue of this effective way of engaging with patients, you actually change the way you deliver services.
Yes.
So you partnered with others and got them to change the way they deliver services. So you're really remodeling the way you work based on this information. So it's an interesting kind of feedback. It's like a PDSA cycle, really. I mean, we're HQO. We should talk about that. That to me is at the end of the day is what you're describing as successes are all about how you then change and remodel the way you deliver your services as a result of that engagement. That's interesting.
And they're not about changing the definition of success to make it easier to achieve. And I do think that that's, I mean, one of the key learnings out of this story. So Michael, should we shift gears and talk about your story a bit, and then we'll come back to a bit of a dialogue?
Sure. First of all, thanks Danielle for inviting me, and delighted to be here with Camille and you. Thanks Josh, and thank all of you for coming here. It's a great turnout. Normally I think in many instances I have a bit of an imposter syndrome. We probably all do, about you're playing roles you're not really sure you can do. Talking about failure, I am the perfect guy, so I feel very much at ease to be here. My wife said, that is the panel for you. So anyway, I come here with fully credentialed. I'm going to talk about a slightly different thing. I mean, there are lots of examples I could give, but actually Josh had asked whether I'd talk a little bit about some global health experiences that I've had. And at first I thought that's kind of weird, but then as I thought about that, there are some really good examples that fit the theme here today. And so one of them I'm going to talk about is some work that I've been involved in over the last decade or so with an organization called Dignitas International. It's a Canadian NGO based here in Toronto that does work in Malawi, elsewhere in Africa, and also up north in Ontario. It's not Dignitas, the assisted suicide organization. That bit of unfortunate co-branding there. They do their thing. Our work is around HIV and health system support in developing countries. And at the time the organization was founded, early on, and this is in the very early 2000s, there really was very little access to antiretroviral medications in most of the developing world, unless you had money, and even then it was often difficult to access. But for the vast majority of people who had HIV, there simply was no treatment available. And it was in that context that the organization initially went into work in Malawi and saw a country, like many countries in the developing world, that were really being devastated by the HIV pandemic. Stories that you're all familiar with: very high infection rates, high mortality, life expectancy in these countries that was rapidly dropping, falling after decades of improvement. Hundreds of thousands of orphans, whole villages where you had basically grandfathers and grandmothers and young children, with the middle young adults essentially wiped out. So tremendous devastation at the time. And looking at, in terms of how could one provide support to these communities when they're facing this kind of an existential challenge. Really, it was about the survival of these countries, of these communities. And one of the things that we noticed was that in the midst of all of this devastation and really kind of hopelessness, when you look at it from the outside, there was an incredible amount of support that was being provided from individuals to other individuals. So obviously from grandmother and grandmothers taking care of grandchildren, but not just that, of course, they were also taking care of the neighbors' children where the parents might have died, or nieces and nephews, neighbors helping other neighbors. If people were getting sick, people would come and their neighbors would come and repair their roof if it was leaking, or bring them food, share whatever meager supplies they had. And the idea was that there's this tremendous energy, there's this tremendous ability, there's this tremendous opportunity here to harness that natural desire to help each other, but perhaps to leverage it by providing some training, providing some resources to individuals so they can become essentially lay health workers. Now, they're not going to become sort of barefoot doctors overnight, but certainly by providing some basic support, some training, they could do a better job of helping individuals who are suffering from HIV/AIDS. And over the next couple of years, as antiretrovirals did begin to become available, help to make sure people were getting tested for HIV, because now there was treatment available, making sure that if they were eligible for antiretrovirals, that they actually went to the health center to pick their supply up, and that they stayed on their medications and so on. So this became one of the fundamental ideas for the organization, was a sort of community-based lay healthcare worker model to harness all of this energy and really transform it and use it in a very positive sense to address the HIV pandemic. It became very much wrapped up in the identity. So you use the word identity. I think it's a really key thing. It became wrapped up in the identity of the organization itself. This was part of the model of community-based care that we were putting forward. And it was a model. It was an idea that was quite novel at the time. So it really became sort of our idea and our identity, our approach to addressing this terrible problem. So we spent a lot of time developing the model. We spent a lot of time developing training programs. We went out and got funding for it from institutions. We raised private money for it. It sort of had an inherent appeal to many people. And when you think about, what's identity about, in large part it's about your own ideology. It's about the way you see the world, the way you see people. And so, our view was these people are good people. They want to help each other. They want to help their neighbors. It's a natural inclination. And so why wouldn't they want to? They already are helping each other, but maybe in sort of disorganized ways or in ways that aren't as effective as they could be. If we provided them with support, they'll do this. And the model became, well, we'll have these volunteer lay healthcare workers who'll do this, let's say 3 days a week, maybe 4 days a week, helping their neighbors, and we'll assign so many patients per lay health worker and so on in each village. It'll be very organized, and won't that be wonderful? Well, guess what? It didn't work. And it didn't work for a number of reasons, and we could argue the details of that for a long time, but I think the fundamental issue was, it kind of doesn't make sense that people are going to be able to do this 4 days a week for free. That they're not going to go to the fields to take care of the crops, that they're not going to make sure their own kids are getting to school or their grandkids are taking care of grandkids, that if they do have work that they're not going to they're not going to do their work, it's sort of, in a way, you can think you could be highly critical and say, well, what did you think they were doing? Did you think they were doing nothing? And they just would, had 4 days available in the week. They've got to get water, they've got to get firewood, and so on and so on. So the bottom line was this whole model of voluntary lay health workers who were going to provide this kind of support to their neighbors really didn't work. And I think what's interesting, I think, for today's talk is the fact that we did recognize it. I think it took a while. I think, like for Camille, we were initially defensive and saying, it's got to be working. What are we doing wrong? Maybe the training's wrong, or maybe we're not attracting the right people, or maybe the people who are coming have some kind of secondary gain from this, and we want to go. At the end of the day, we realized, no, that fundamentally the model just is not a sustainable model. It might work for a while for certain people, but it's not scalable, it's not sustainable. But because it's wrapped up in your identity, because it's wrapped up in your ideology, because it's wrapped up in the way you see the world, how do you switch gears? So that took a while. But what it did do, I think, in a very positive sense, and I guess this is the way it changed the organization fundamentally, was that it made us really orient ourselves into an operations research framework to say, if we're going to be implementing a new intervention, like a community health worker, or any other kind of intervention, we need to evaluate it. We need to understand, what is our theoretical framework? Why are we expecting this to work? And what are all the assumptions that are built into those, to that framework, each of the steps along the way that gets from the start of the intervention to the successful outcome. And do those assumptions actually make sense? Can you test them? And then in the real world, if you're happy with your theoretical framework, well, test it. Design your intervention so that you can evaluate it in as rigorous a way as you can. And accept the fact that, yeah, your identity is going to be changed as a result. Your ideology may even be changed, but certainly your understanding of the world and the local context will necessarily be changed. So we're going to stop there, and we can open up the floor for conversation.
It's such a rich story. And one of the things that immediately leaps to mind for me is, how do you know when to walk away? It's sort of like a bad relationship or something. How do you know when you're on a break, and how do you know when it's time to file for divorce? Because, of course, we do get emotionally committed to these concepts and these ideas, right? And we do, and I think we all, especially, we're all kind of into the quality improvement, universe, and we all believe that iterative change is good, and so you try something, it doesn't work, you tweak it, how do you know when to just say, you know what, this idea, it's time to shut it down? And especially in terms of healthcare system reform, where interventions are expensive, and they are public, and ministers have to answer about them in question period. So to stand up and say, this diabetes registry, failure, like, let's walk away from it, or this whatever, like, it's just not happening, and have the courage to do that is incredibly difficult when it comes to healthcare system reform. So so how did you know, can you describe that process within Dignitas, where you actually said, okay, we're done here, we're going to move to something else?
Yeah, not really. I mean, because it was a process. There wasn't sort of there wasn't a key meeting that on November 2nd of 2009, we sat down and looked at the data and said, no. No, it was a process, right? It's sort of a gradual understanding, and I think that is part and parcel of the process of changing the organization. I think now, because much of the work that we do, so just a full disclosure, I'm the chair of the board of the organization, so take what I'm saying with that grain of salt, I guess. But I think now we do a much better job of evaluating the interventions as we're implementing them, and if we see that if we see a study that shows that it doesn't work, we actually change it. And that has the advantage of I think doing a couple things. One is, of course, yes, you abandon certain approaches, but you also open the door to very new approaches, and it's only when you shut down the one that you can really launch the other.
So I think, this thing about evaluation I think is critical to this conversation. So before we start to open things up to a broader discussion, I'd like to maybe talk a little bit, the three of us, about evaluation. It's
Danielle, just before you go
yeah,
to evaluation,
sure.
there is, just listening to this story, in Ontario, in the early 80s, 90s, when the AIDS landed in Ontario, in Toronto, and Toronto was the mecca because everybody came into Toronto for care, we did exactly the same thing. The bulk of the people who had AIDS were gay men, predominantly started out with white gay men, which meant that the community got behind it and rallied, but the community had the time and did the bulk of the work around volunteerism. The hospice, Casey House was built by the entire community. All of that care and support was done by the community. And so everybody embraced it and it was all wonderful. And then we started to see women of color, African women, with AIDS. But they had to work and look after children. They didn't have the time to do all this volunteerism. But we had already built a whole system on hospice and volunteerism and support for the dying that wasn't sustainable. So one of the things that is important for me, is interesting, is how, I don't know if we ever did a review of that, except all of us who were doing AIDS work knew it didn't work, started to say we can't build this on volunteerism. But I don't think we ever did anything beyond that so that knowledge would have been shared.
So maybe that's a failure to learn from failure, right?
Yes.
And actually, for those of you who are interested, one of the things that first got me interested in this topic is the work of an organization called Engineers Without Borders, which is an international global development organization that does, work all over the world. And in case we think that what we're doing in healthcare is the only place where it matters to people's lives, like these are the people that are building the wells and the bridges and the basic community infrastructure to make sure that clean water gets to communities, et cetera. And every year they publish on their website a beautiful, glossy failure report. If you Google Engineers Without Borders failure report, it will pop up and you can read them, and they are fascinating. And they are absolutely relentless about evaluating the stuff that they do, and then they actually talk about celebrating their failures, which I think is really a radical concept, and I love it. And they, again, these are high stakes environments. They're not talking about celebrating the failure of the death of the widget in the marketplace or something. This is really important work, but they feel like this is how you develop this culture of learning from failure. And interestingly, I think it was maybe 2 or 3 years ago, they published sort of a meta report on their failures to learn from previous failure reports. And so they, it's that everything old is new again, or whatever thing, where they actually looked at some of their recent failures as an organization and identified that the themes that arose out of those failures were old themes that they had visited before and that they had sworn they were going to learn from. And so I hear echoes of that in this thing about volunteer. I mean, we're all for volunteerism, but maybe it doesn't always work in all places at all times, and understanding what the other pressures are in people's lives might help us to know what limits their capacity to engage in volunteerism with respect to healthcare. Lesson learned in Malawi, lesson learned in Toronto, lesson learned probably 50 million times, replicated all over the world. So is it an absence of cultural competence in the area of failure that forces us to keep failing in the same ways over? At least we could be making different mistakes.
And where I see this learning from failure and stuff is really important, and around volunteerism, I see a whole trend in healthcare now about things like care of the elderly, care of seniors, care of parents. And then we jump from that very quickly into cultures and say, they take care of their seniors, and then nothing about what do we need to do to provide support, because they will take care of their seniors. But these are the same people who are working 2 jobs,
Right.
raising children, doing all of that, but also taking care of their the seniors. And so underneath it, we are beginning to develop this culture of volunteerism, even if we don't call them volunteers, we call them caregivers.
Right.
So it's probably, it's probably not that people aren't willing, if we're going to talk about volunteerism,
Yeah.
they're not that they're not willing
Right.
to do the work. Of course they are.
just not
But
able
what are the key obstacles? Like, what are the
Right.
things that they really need to do that job effectively? And what are the frustrations that they face that make them give it up, right?
And can we really expect them to do that to the extent in which we are designing the system for them to do it?
Right.
Right?
But it's not just about volunteerism or about caregivers and so on. I mean, you think about a lot of the things we're trying to do in the healthcare system and make changes. So we're making a lot of assumptions about changing work roles, expanding
Right.
skill sets, task shifting, and so on, without necessarily thinking through, okay, is that actually feasible to add that on to whatever else there's already on the plate, or to substitute what you're taking off someone's plate with other things. So for example, think about primary care, and you think about your area of expertise, not mine, but when you think about, a lot of thoughts around shifting away from primary care physicians, some tasks that could be done, say, by nurses or nurse practitioners, and then what? Substituting that with the care of complex elderly or complicated mental health? Fine, but what supports does a family doctor need when a schizophrenic comes into his or her office
Right.
who's poorly controlled and they can't get in touch with a psychiatrist or any kind of support? Or it's this kind of simplistic notion, I think, so often of task shifting that just assumes that either expansion of scope of work is okay, and there aren't additional supports necessary.
So let me ask you about that then. If you, because you're the evaluation guru, if you were in your family health team or in your hospital or in your community trying to design some system change, and your solution included some form of task shifting or some assumption of a role that didn't previously exist for an individual or group of individuals, how would you go about looking for help in how to design that outside of the standard literature review? Because Camille's telling us that stuff didn't get published, the experience of treating people with AIDS in Toronto in the 1980s, but everyone who'd worked in the AIDS community knew it. So how do we draw lessons, and how do we create organizations that are learning from the failures of others if those don't exist in the classic literature?
Right. So I think, first of all, it's hard.
Yeah.
So it's not, fool ourselves. This is not something that you just kind of figure out or read a paper and you do it. I think the first thing is, the literature, the evidence that's out there is helpful to an extent, but often not perfectly relevant. It might be something that's done in the U.S. and you're trying to do it in Canada. It might be in a different type of system that has different incentives and so on. It might be something that's done in a different era compared to yours. And we also know, of course, that the only thing that ever gets published are the positive evaluations. Nobody is trying to, people may, even if we have failure culture where we're trying to embrace failure, Engineers Without Borders is the first organization I've ever heard of that is actually publishing their failures.
Right. It's
pretty hard to get them published. Not impossible, but hard. So you just know there's a bias in terms of what you're going to see, things that will likely say it works. So I think that's a good place to start, though, in terms of thinking through what it is your intervention will look like. But I think this notion of the logic model or the theoretical framework is really important, and there are some really good examples out there, easily available, if you Google them, of kind of just sitting down and thinking through all the various steps in the intervention. What are you actually doing? And what, in each step, or each individual who's involved in that, what are they actually doing? What are you expecting that will result in? What are the resources that are necessary for that to happen? What do you expect that would change in the short term? that might be just around processes or around different ways of working. And then if you achieve those changes in processes and ways of working, what do you expect that to achieve in terms of longer term outcomes like patient outcomes, better satisfaction or, better quality deaths, for example, for palliative care patients, or maybe it's better quality of care. And I think that kind of very deliberate effort, and doing that in a serious way where you do it as a team, where you're really kind of questioning each other and pushing each other, is probably the first step towards building the intervention and then evaluating it. Because what it allows you to do also is to then, as you're implementing, to check on the progress. So a lot of those interim steps,
Right.
I think A will lead to B. Even though what you want to achieve is over here at D and E, you have to get from B, C, you have to get from A through B and C to get to D. You can probably measure those interim steps much more easily in terms of whether things are happening the way you expect them to happen. And if they're not happening, for example, there's a great model of care called SCOPE at a women's college that you know well, Danielle. And one of the things is a telephone hotline, a navigator that a family doctor can call to get support for their patients. Well, if you think that navigator will enable the family doctor to have better access to specialists and diagnostic imaging and all that, that's great. But you better measure how often the phone gets used. How often are calls actually happening? Because if it's not actually, if no one's calling, it's not that the intervention as a whole was wrong, but maybe no one's using the phone anymore, maybe you didn't do a good enough job of telling people what the number was, and so on. So you can figure out why things may not be working. The worst thing also, I think the kinds of interventions that we're talking about that aren't sort of a new drug, a new pill for hypertension, but are generally system re-engineering. Even that system is fairly localized, like around the care of frail elderly. That's still a complex intervention involving multiple players. These interventions, the evaluations, I think one of the mistakes that it is often made, and frankly, evaluations that an organization like ISIS often makes, which uses administrative data and is often looking at big picture outcomes, like did people get admitted to hospital, did they die at home, this kind of thing. Whether it succeeds or fails, if it fails, we're often left to say, well, it failed, but we can't tell you why. We can't tell you about any of those interim steps because we don't have the data. So unless you're collecting that data locally, you won't be able to tell it was because no one used the phone, or it was because even people were using the phone, the navigator couldn't get in touch with the specialist when they needed to. You need to understand why it failed, because then it allows you to tweak it, to change it, as opposed to just abandoning it.
That's really helpful.
The second thing is if it succeeds, it may be that you've planned this intervention that has 20 moving parts to it, but if you don't understand it well, you may not realize it. Only really 7 of those 20 pieces were really key. And those are the things you need to invest in. And the others were kind of superfluous and you could do away with. And that's really important for scaling as well.
Yeah, for sure.
The other piece that I think is important that is to be clear what the outcome is. And in healthcare, we love very quickly to say we can't do outcome because we don't control all of the moving parts. But if we're saying, for this patient or for this community, here is a difference that we should accomplish. So like the presenter this morning, half of those things may be difficult, but they're not impossible. And we very often stop because it's difficult.
Right.
And I think we need to be able to say, okay, we tried this doesn't work, but we still have the problem. So what else are we going to try to get at the problem?
Right.
But then it's that persistence of looking at new and different ways to still get to what it is we need to get at. Mm-hmm. That's important. And so for me, in the patient engagement realm, we're going to fail. We're going to try going into talking to African women, and the first one may fail. Mm-hmm. It doesn't mean we don't need to hear those voices. Mm-hmm. So we have to think of new ways, different ways, and creative ways to get it done. And the other thing is it takes time. But at least we need to be clear that we're still going to make that difference. And I'm not sure that we're always that persistent in that difference. We stop at the difficulty of the provider.
Right.
And it's the providers who struggle, it's the providers who can't, but the patient at the other end are still left not getting the improvement. Mm-hmm. And I think that's the system view that we have to keep that And if we can't achieve that, that's where we still need to acknowledge that we're failing.
Right. That's helpful. Can I ask the people who are at the computers at the back to advance the slide? It's not critically necessary, but this is the point where we're going to ask you to join in. There we go. And I'll keep going. Fishbowl slide. Yeah, there we go. The fishbowl is open, folks. So the idea here is we're hoping that some of you will be willing to come up and either share a brief story of your own that you think contributes to the conversation, or respond or ask a question of our panelists around this concept of failure. So who will be the brave first soul? Terrific. Come on
Chairs
up.
are really comfortable.
Come on up. So the idea is flow. Just come on up, grab a seat. When you're done, you can move away and someone else will sit in the seat. And maybe just briefly introduce yourself.
Sorry,
No, please. There are 2 chairs.
So I've spent my entire career across all sectors in the decision support departments.
Mm-hmm.
So when the LIN's accountability agreement shows up in the organization, it usually drops on my desk to try and figure out what we need to do over the next little while. And nowhere in there is the ability not to meet your indicators. As a matter of fact, a lot of the time the corridors that your organization is allowed to fall in don't even exist. It's just a target that you have to hit. Otherwise, at least as far as many of the service providers are concerned, their funding will disappear. So there's a lot of fear that happens between the health service providers and the LINs. I don't understand it personally because I actually do read the accountability agreements, and it's a two-way agreement, and the health service providers should be at the table as much as the LIN, telling the LIN what we need and what we don't need. So I think the first thing to do is sort of turn that back into a conversation and less of a budget fear situation.
So to answer to that, I'm not sure where the failure element in that is that there's a perception then that the provider have failed or the LIN have failed. Because we work in a full system all the way from government funding all the way through. So we do get these metrics. Most of them are really designed to improve something. And so I can only speak for Toronto Central LIN. Our commitment to the metric was, for example, ALC. We were going to reduce ALC rate because it's not good for patients. Mm-hmm. And yes, it's taken a long time, and you have to stay on it. But at the end of the year, we still go back and argue with government that we didn't hit the target, and here is why. But we're still accountable to know what we're doing about moving it. And I find it very often we stop too early in that I didn't hit the target, but there's really no information about what was done, why we aren't meeting it, what the next steps are. Because we stop at you meeting the target, not meeting the target, and I don't know.
Yeah, I've always been the advocate that the organization has to be proactive. You have to know where you are according to those targets, and when you see yourself not about to meet them, you don't tell the LIN a week before the end of the quarter. You tell them immediately when you see it and say, well, we're going to have to discuss where we're actually going or what we're going to need to get there. But the fear is still there, the sort of lack of open dialogue to discuss. We're not, like, we'll tell you about our failure 2 weeks or a week before you actually get the data.
And I do think we have to change that culture because for me, the conversation is we're in this together, and at the end of it, it really is about patients. So we both have the commitment to make that improvement, and what's the dialogue? How are we going to get there? So I can just give an example. In Toronto Central in MRI, we were always red on MRI. We pushed hard on a number of other indicators to move it, but on the MRI one, the team with the providers broke it down into, we're hitting MRI 1 and 2. Those were the critical clinical one. We're not hitting 4, and we're okay with the red because we now know which MRIs we're not achieving. And then we turn it around and start to question, is that even a question now of appropriateness?
Right.
And so there's a whole bunch of work that has been done about appropriateness. But it is the work of working there together. The fear I don't find helpful I don't find the reaction from a fear point of view helpful. I do think the dialogue.
I also don't think it's realistic. All the conversations I have had with Lynn people about not meeting deadlines or missing on targets, as long as you can provide the story and the data as to why, there's really no reason for fear, but
So-
it still exists.
So I'm going to pull Ivan into this and ask if you were you along these lines of fear versus open arms or something else?
My question was going to be different, but I can jump
Okay.
in. I guess what I see is that embracing failure doesn't mean losing accountability. I
Right.
think from a Lynn perspective, from an organizational perspective, it's important to be accountable given it's a publicly funded healthcare system. I guess in order to be accountable, you have to measure it, but whether you succeed or fail on those particular measurements doesn't necessarily say whether you're doing a good job or not. I think it's about investigating and answering some of the deeper questions. A metric is only able to answer so many things, and I think that bringing in other aspects of care into how we measure is important. So, I think what we're doing with the MRI is great in terms of answering the accountability question.
So I'm going to thank our first participant. You were very brave, and Ivan, you had another question or another issue you wanted to
Sure,
raise.
yeah. So, my name is Ivan, and I'm actually from decision support as well at St. Joe's Health Center. So my question is about the qualities that make leaders comfortable with failure. And what do you think those qualities are? And do you think those qualities are at odds with kind of how those leaders became leaders in the first place? You often hear questions about, what have you achieved, or, and just driving to success. So I guess, are those two things counter to each other?
So I'll start. I mean, actually, interesting. Camille and I were sitting here just before the start, and Camille made a comment about kind of a point in our careers where we become, and I think. I think you don't get to, I mean, you get to various points in your career in all sorts of ways, but if you're leading an organization, I think largely you're going to be a better leader if you're honest, if you are just kind of straightforward with the people that you report to, your board or government, or your boss. And I think most people are pretty reasonable. And I think if they can see that you've made an honest effort, so the point that Camille was making earlier about, well, you may not have met the target, but look at what you're doing to try to meet the ALC target. And if those steps are reasonable, and one of the things that I was taught about being a good boss or a good manager is that you don't necessarily need to know how to help someone do their job if they're reporting to you, but you need to know how to help solve their problems when they come to you with a problem. And if the ALC target is not being met, and you go to whoever you're reporting to, and they have no other nothing to offer in terms of solutions you haven't already tried, it's hard for them to be critical. So bottom line is, I don't think that most successful leaders will they're not going to necessarily trumpet their failures all the time, or maybe listed fifth after 4 successes. But I think honesty typically, and being straightforward, and dealing with failures, because that can ultimately lead to success, obviously, is part of individual success as well.
I think there is a place sometime where your life history, your family history, your experience does make a difference. When you look within the North American, Canadian context, almost everybody in this room, I'm pretty sure in our life story, were straight A students, 90%, 95%, and there's a whole culture of that, right? I see kids now who don't know how to deal with failure even at 5 or 6, because everything says you're wonderful. So we no longer even teach our kids.
We get feedback by the peanut butter model, right? Good, bad, then back to good, right?
Right.
So I do think that's also a cultural piece where you learn that you're not going to be all that all the time to everybody, and how to live with that and live comfortably in that. And so I think self-worth, which you don't have this sense of being an expectation of having been right, and also to convey to others it's okay to fail. It's okay to not always be right, and be comfortable in that is a good thing for me. And I think leaders need to be judged on that as well. not only the 95, 98, but how well do you sit in that place where you haven't been, and how do you embrace it? And I think sometimes your life history allow you to have learned failure, or not to be liked, or not to be the top of the game, or not to be first. And those are good life lessons that I think you take into leadership.
But do you think that as a leader, you can give that, parenting message of you're a good person who did a bad thing, as opposed to you're a bad person, in order to help people who may not have such well-developed muscles around failure to get a little bit stronger or more resilient around it, so that they won't be so afraid, to stumble occasionally? Are there ways that we as leaders can help our organizations and the people in them be a little less, judge themselves a little less harshly if they don't meet every target?
I guess the first thing is to do what we're all saying we are supposed to be doing, which is to say it's okay to fail, that there are things that, okay, you did these things to achieve that, it didn't work, what are we going to do for next time? And I think part of the issue is about allowing things to die. Not people, but I mean ways of doing things. I think we're particularly bad at that in the healthcare system. It seems that we always keep trying to do things the same way, and there seems to be so many challenges to even switch from a fax system to some other system for communicating. So allowing a process, an intervention that has proven that it is a failure despite efforts to become extinct is an okay thing. And we all want the health system to evolve, and one of the outcomes of evolution is that things become extinct. And so that's probably not a bad thing too, to be able to say, okay, that didn't work, let's really abandon that,
right,
and then work in a different way.
So it was a great question, Ivan, thank you. And I think, I'm reminded of a story that was in one of these Harvard articles about failure with the tech VP who got brought in at huge cost to one of the fancy organizations. I don't remember whether it was Google or what it was anymore. And early on in his tenure made a bad decision that cost the company a fortune. And he got called into the CEO's office fully expecting to be fired, which is what would actually happen in healthcare, right? In Ontario, we scapegoat people pretty fast if they don't meet the targets or they mess something up. And the guy said, well, I guess I'm here because you're gonna fire me. And the CEO said, are you crazy? We just made $1 billion investment in your learning. Like, the last thing we're doing is firing you now. You're gonna stay here and work this out because you made a mistake and it was not a good move that you made, but you're not a bad person. You're still the person that we hired 6 months ago or whatever it was. Thank you very much.
Thank you.
Charles.
Thank you, Danielle. Hello. Thank you, Danielle. I suppose I should declare right away I'm a member of OTAC, and I was chair of the Ontario Health Technology Advisory Committee until earlier this year. I was going to change the conversation a little bit along the lines, somewhat along the lines of what Michael just mentioned. We have come a long way, there's no question, in terms of, if I could put it another way, learning from mistakes, learning from success, dealing with failure appropriately. In other words, don't blame people unless it's strictly necessary because of gross incompetence, but fix the system. But it's noticeable that everything we've been talking about so far in this whole meeting, I think, I haven't been to every session, obviously, you can only go to 2 of the breakout sessions, has been on either a micro or a sort of medium level. In other words, we're talking about programs, we're talking about spectacularly, for example, this morning with the story that we heard in the powerful opening session, one individual who exemplified such a series of issues and is being dealt with appropriately. But when it comes to thinking of failure, let's talk about our failure to evolve transformation. Does anybody here really think they have ever seen anything transformational happen? And yet we keep using the word. It's as if we keep nibbling at the edges, as you've also referred to before. And we were doing our very level best and working hard to get the best programs and to the best patient care that we can, and to solve a lot of the problems. But what I see is some spectacular failures on the macro level, and I'll just give 2 examples and see how the panel responds. First, the absolute failure of senior political leadership in the country, to the point where the provinces have been told to get out of my face, sort of thing, and do what you can to fix your system. And to a lesser extent, the same thing happens in the provinces. There is apparently a total lack of appetite at the very most senior political levels to bring in the kind of changes that could lead to transformation. Now, once again, I'm going to ask if anyone in the room knows of any national or major provincial or state system in healthcare that has been evolved and taken place without legislation. It's a rhetorical question. And just to name another for you to think about, there's a spectacular failure of the physician social contract at the moment. I was thinking of that very strongly this morning. I'm wondering if everybody knows what I mean by that. I mean, we have what is approaching a disgraceful situation, and I know, don't tell me you can't tar everybody with the same brush. Of course you can't. But overall, there's a spectacular failure in the physician social contract of care in response for all the privileges that physicians have. And incidentally, it's not the only profession, but it's the one I know best in which this has happened, and it's been transformed into a business in which we're even having trouble satisfying such basic things as 24/7 care.
Well,
So I would try and tackle that by saying we could be very flippant and say, yes, there's been spectacular failures, but we also live in a democracy. We also live in a society where there are changes come about through a number of levers changing it. I think if we were in an autocratic society, you can get transformation because you do have a dictator who get up and says this shall be so, and it is so. And even then, that doesn't quite work. So yes, I think everything you have said is true. The question that I would ask is a slightly different one, is if we perceive that there's a failure in the social contract in physicians, what do we collectively do to make that change? Because I don't think it's just the physicians who wouldn't be doing that. They would respond. In almost everything we do, there is a push and a pull. And to what degree have all of us risen up to make that a priority and argue about it, and so that then you get a different response? So I do see a lot of physicians beginning to step up, but I also see a lot of the public begin to demand, and I also see a lot of healthcare folks. So how active are we all in owning some of these issues and becoming activists in advocating for these change? And that for me is, I can see that failure. I could also be cynical and say I see the failure of all the rest of us in not being active participants in advancing those agendas as well. Because I think it's a combination of those things that get transformation. I mean, my own personal one is that I usually say to folks, you know, slavery didn't end because somebody got up one day and thought it was a good thing to end it. It ended because all along there was a whole series of people and that thought that it needed to change, and it's a coming together of all of those that ended up in the change. And so I think if we want those changes, we need political action, and we are part of that.
So I think you've raised a couple of very important points. I guess on the first question or first point you made around government and government's engagement, I think it goes back to identity and ideology. I mean, the government of the day at the federal level has a particular ideology about healthcare and division of powers and what they're going to do or not do. And frankly, I don't think I think a political party is probably the least likely place where that identity is going to be questioned, and those fundamental values will be, changed and tweaked through PDSA cycles. So I think, as citizens, we get the government we deserve. We elect our representatives, and this is the cards that we're dealt with right now. I think in terms of the sort of system transformation examples, I mean, I'm not sure exactly what you're referring to. If you look across the world, across the developed world, there are many examples of, mixtures of private and public healthcare. You have universal healthcare in Canada and other countries. And every single country is struggling with a range of issues, some struggling more, some struggling less, but nobody's kind of nailed it yet, I think. So I don't know that we can, anywhere in the world, you could point to some massive transformation of the system as a whole. However, I think you can look at some pretty impressive things that have happened. I started off talking about HIV. I mean, look at how far we've come in about 15 years in the HIV pandemic. This is a global epidemic, which is now, when we're talking about, an AIDS-free generation, that we're not there yet, but we may not be that far away. We're talking about people who, even in Africa, can have a normal lifespan when they have HIV/AIDS if they're on treatment and follow it. And we're now talking about how to manage the chronic diseases that these individuals get. So, I mean, I think it's not all dark and gloomy. Physician social contract, absolutely. I think there are substantial challenges. I'd go back to the point to say, okay, so what is it? Do we understand really what the barriers are that allowing physicians to provide 24/7 access? And how willing are we to have the fights that are going to be necessary to make the changes? In some cases, fights, but not in every case, to bring about the kind of system that we think we need.
So I'm going to ask our final Fishbowl participant, thank you, Charles, for the last word before we wrap up.
Okay, I'm taking you.
Yep, it'll go, don't worry.
I'm taking you from a macro to a micro level. I'm sorry, and my name is Dale. I work in long-term care in the Toronto Central Lynn, and I wanted to just mention the endless frustration and countless hours that are going into all 600 and some odd homes in Ontario, trying to fix falls, trying to reduce restraints, and trying to reduce wounds. And I think that every home has a failure story, and some homes have success stories. And I think that we're all missing out by not being able to trap that information and use it. I know that every place is different. The arrangement is different, and I don't have your global perspective on things, but it's very frustrating to me that 600 homes are trying to fix falls and wounds and restraints, and we're all fighting together and completely in isolation. And I was wondering if there's anything that we can do to help that process along.
It's such a great point, and in fact, it has been said of Canada so many times, it's sort of a truism that we are a nation of pilot projects.
That's right.
And we do such a poor job of scaling up success. And so one of the reasons that we're having this conversation about failure today is because we're even worse at scaling up failure. Like, how many times have we repeated failed experiments across the sector because we didn't know?
Answer that question?
Sure.
Are you guys doing your QIPs yet?
Yes.
Okay, so in the Q Care, this is the first year for 14-15. We're going to report on our failures and our successes with our indicators. The HQ is going to pre-populate our change ideas. And so if those have been on your QIP, those will be publicly available. And you can look at other homes and see what they did for ulcers and falls and see what worked and what didn't.
That would be great.
The piece to that too, though, is what we're trying to get at, which is the overall cultural change, which means all the homes, everybody in here, everybody beginning to work together to get a comfort zone where we can talk about what worked, what didn't work, and to share that. And we don't have an infrastructure or a way of doing that yet, because we do not yet have enough people who are feeling comfortable with that. So that's why I was so drawn to this presentation, to say, if we can begin to get more people do that. So for example, when we bring all the long-term care facilities together, we could make an agenda item at one of the meetings. Let's talk about wounds, let's talk about the failures. And if everybody is willing to come and talk about it then the vehicles can be there for it to happen. But I think the first piece is this kind of conversation, so that if you put that on, people are willing to then come and talk and learn. But right now, it's really difficult, I think, for a lot of us to talk about what hasn't been successful.
So on that note, I think, for those of you who are in the room, you will recognize that I do think this is a conversation in its infancy. And what we're trying to do here is to get a ball rolling about a different way of talking about failure, because it's not a question that we're going to fail. It's just a question of how we deal with it in the healthcare system here. And so I would ask that people do take the time to respond to the survey that's going to come out to you, because one of the things that we're struggling with between HQO and Women's College and other organizations that are trying to advance this work is, how do we get this conversation, build some momentum around this conversation, and what are the avenues available to us to start to scale up the learnings that we've been struggling with today. And to your earlier point, it's going to be hard. Like, it's not obvious what the path forward is, except that I think that there is a feeling that this is an important issue to start to talk about.
One comment quickly, just one last comment. Just one of the things I think we haven't talked about, and is I think a barrier to all of this, is the willingness of the public and the press to accept failure. And I think, if I'm working in the long-term care facility that our last speaker was in, it's the press loves this when you're the last on the list, right? And you're held up as this terrible long-term care home that does all the falls. So can we have a conversation not about a long-term care home, their fall rate, but about failure as a means to eventually improve the system that would involve the public, that would involve the press? Let's get Andre Picard writing some stories about this, because I think it's fine for us to embrace this, but we probably probably want to keep the doors closed if there is press out there in the public as we talk about this at this point.
It's a critically important point. And so if people in the audience have ideas about how to do that, and similarly, I think for our political representatives, I mean, when was the last time somebody scored points by standing up in question period and saying, we had this policy idea, we thought it was a good idea, we invested $100 million, it didn't yield anything, sorry about that. And yet, of course, that's what's going to happen, that's what's going to be required if we're going to achieve the transformation that Charles was asking about. So thank you for being willing to participate and stretch your minds in different directions today, and we look forward to hearing your feedback about how we can carry this conversation on. And thanks to our terrific panelists.